That's what I'm going to talk about today, and let me start by some pathological consideration and remind you that due to the ingenious structure of the basement membrane, everything is in its place. Proteins are not allowed to be in the urinary space except just a little. When disease happens and this wonderful mechanism is altered, the capacity of the proximal tubules to catabolize all this excess protein is overwhelmed and damage starts. Damage starts, the proximal tubules start to secrete a lot of inflammatory mediators. Maybe they pass into senescence as well, and senescent cells naturally will damage the neighboring tissues. Eventually, we have a state of scarring, and the GFR will decline, and things will progress until end stage. That's why proteinuria is serious. For many years, we have been using RAS blockers, and we understand that tight blood pressure and tight glycemic control are important. Yet, there are patients that still, in spite of using RAS blockade, do have residual albuminuria. So, the toxicity of this albumin is going on. We have to do something about that if we can. The standard of care therapies that we all are using now, let me start by the RAS blockers. For ages, we know that for many decades, more than 30 decades, that angiotensin 2 and aldosterone, both of them are serious hormones that are leading to the progression of chronic kidney disease. That's why we are trying to use drugs to stop the action of these two hormones. And apart from the hemodynamic effects of RAS blockade, we understand as well they have other mechanisms such as decreasing injuries due to oxidative stress, inflammation, apoptosis, and also enhanced the production of nitric oxide, which is important to maintain the vasodilation and integrity of the endothelium. We're not supposed to combine ACEs and ARBs together. I know that this is a fact, but if you really have to do that, apart from this guideline, I don't think we have to worry so much about hyperkalemia now in the presence of a novel therapy such as the sodium zirconium silicate, which could really help us in particular situations. And of course, it will expand our use of RAS blockers right till the end, which are needed to prevent the progression of disease. If you want to take things a little bit higher up the scale and use aliscrin, which is an anti-renin drug, you can see from this earlier work that it has been shown to be even more potent in decreasing proteinuria when compared to an ACE inhibitor such as prindopril. CCBs, we have more than one form of CCBs. I guess everybody understands that the non-hydroxypyridine forms are what we need in nephrology rather than the vasodilatory, the hydropyridines, which could be even used to treat migraine. Now, the renoprotective effects of these calcium channel blockers, as pointed by Professor Saadi a couple of years ago, is related to the type of receptors that these particular calcium channels are linked to, the LN type and the LT type, and this is how these CCBs produce their renoprotective effect, apart from their hemodynamic ability to dilate afferent and efferent arterioles. Lots of nephrologists are forgetting that diuretics also have an effect when it comes to proteinuria, and it's forgotten. Maybe as this publication showed that it could reduce proteinuria in more than 35% of cases. And there are various trials addressing how diuretics may be helpful, but as you can see, all of these studies is linked to the use of a diuretic together with a RAS blocker. So in reality, diuretic itself does not have an inherent ability to decrease the proteinuria, but rather through potentiating the antiproteinuric effect of the RAS blockers. And never forget also to apply salt restriction to these patients. Coming to the last part of my talk, which is the new drugs, and I have divided the new drugs to all drugs with recent evidence of nephroprotection, as you can see listed, and the new drugs. Starting by the incretin, the DPP-4, GLP is a wonderful hormone that has various effects all over the body, And when looking to the kidney, you find that it increases natriuresis and decreases renal inflammation and oxidative stress. That's why an incretin such as DPP4 not only is good for controlling blood sugar, but does have some nephroprotective actions as well. Taking you to the old drug that I favor so much, metformin, and as I call it, a drug with many faces. Why with many faces? Because it has pleiotropic effects, as you can see listed here, not only nephroprotection, but anti-aging, used as adjuvant therapy in cancer treatment, and autosomal dominant polycystic kidney. And lately, it is also used to prevent the progression of non-diabetic CKD disease. Metformin, as you can see from this publication, is being well established in this regard regarding retardation of progression of chronic kidney disease. And how metformin is doing this, it's doing this due to its pathogenetic mechanism. And you can see from this diagram is related to activation of the activated mitogenic protein kinase, which will result in suppression of the translation overproduction of mTOR. And once this happens, you are protecting the cells from further damage, enhancing autophagy, and the disease cells will be able to clear themselves as well as decrease the amount of matrix production. AMPK in this recent publication has also been linked under the influence of metformin to other disease areas such as it's good for lipogenesis and cancer progression. So metformin is coming very favorable nowadays to treat various disease areas. And maybe this recent publication is interesting. Yet another new mechanism has evolved to show how metformin is producing these effects through probably activating the HIF2 alpha vascular endothelial growth factor signaling pathway. And this has been an experimental work in hypertensive rats with proteinuria. And this was the explanation of the effect of metformin. Taking you to the old pentoxifenolin used for ages to treat vascular insufficiency, yet since some time, there were various studies looking at pentoxifenolin in relation to proteinuria, and according to these studies, it was comparable, quite comparable to the effect of captopril. A more recent trial known as the PREDIAN trial definitely showed that using pentoxifenolin does not only reduce the amounts of urinary albumin excretion, but also prevents the progression when compared to controls of a decline in GFR. So pentoxifenolin seems to be quite interesting. Not only that, you can also add it, according to this publication, to RAS blockers. So we have a wonderful armamentarium today full of drugs that are safe to combine together, and yet this is a very recent trial that is still recruiting patients to really place pentoxifenolin where it should be, where they are going to test this drug in about 2,500 patients, whether diabetic and non-diabetic. When we have results for this, we can answer the question about using pentoxifenolin. The MRAs are involved in various disease areas in the body, and looking at mineralocorticoid antagonism, it's quite beneficial and been used by cardiologists since a very long time to help the injured myocardium in what is known as remodeling, and in the kidney, they have been helpful in hypertension, ischemic insults, and even glomerular injury. That's why they are favorable to use nowadays, as I will come to show you. Looking closer at what these drugs are able to do in the kidney, you can see they decrease the amount of fibrosis by reducing the collagen synthesis and reducing the fibroblast proliferation. Not only that, they help in the podocytopathy that could occur in various disease areas. Also, they enhance the production of nitric oxide and promote vasodilation and many, many other things. The effect of mineralocorticoids on proteinuria and progression of chronic kidney disease was assessed earlier in various trials with quite significant results. And always the problem was with using the MRAs, the side effect, the dreaded side effect, which is hyperkalemia. With the development of the latest version of MRA, which is the phenylneuron, things have changed, and hyperkalemia wasn't that significant these patients, and the trial was arrested, was stopped earlier because they achieved the primary as well as the secondary endpoints. It was very amazing, the results of the Fidelio trial, to be followed also by the Figaro trial. And astonishingly, you can find a sustained more than 57% decrease in the progression of GFR, which is really a very significant result. So MRAs can be used safely, not only in diabetics, but non-diabetics. Yet one question, can we combine it with SGLT2 inhibitors or not? Only 5% of the patients were already on these drugs. So now they are designing a trial to test using both drugs together to answer this question clearly. Probably yes, but I cannot give a straight answer without being backed up with evidence using SGLT2 inhibitors with MRAs. This is a very interesting trial because they are testing the old trials again, and this was published just last March. They looked into the old MRA, spironolactone, and the predecessor epineuron, again, proving that both MRAs are very effective in preventing progression of chronic kidney disease and decreasing proteinuria. Again, if you have a problem of hyperkalemia, you shouldn't worry with what is available now. Vitamin D, we all respect vitamin D nowadays and understand how it is pleiotropic in our body, particularly that it has the capacity to suppress the renin-angiotensin aldosterone system, very, very important thing. And this early trial tested the addition of 2 micrograms of paricalcitol to RAS blockers, and they showed in the results that it could really lower the residual albuminuria. So adding vitamin D to RAS blockers was quite beneficial. Already these patients may be taking vitamin D as a replacement therapy when they have hypovitaminosis. Why is vitamin D helpful? Simply because vitamin D is represented in the podocytes. The vitamin D receptor, the VDR, are present in the podocytes. That's how the podocytes can metabolize vitamin D and protect themselves. And this is a recent work saying this particular point about the vitamin D receptor activation within the podocytes. I came across this, maybe it's not too much out of the way, but just to show you that in systemic lupus patients with proteinuria treated by hydroxychloroquine, that addition of vitamin D has also been helpful in reducing proteinuria. SGLT2 inhibitors is in fashion. Everybody knows how it works, so I'm not going to go through all these details, but just rather remind you of how CKD progresses. It is through these 3 serious channels. Hemodynamic pathways, you all know these details. The metabolic pathway related to hyperglycemia, increasing glycolysis, or the dreaded and difficult to treat inflammatory pathway. This is how CKD progresses. We should target all these 3 channels in order to do something about this CKD progression. And a lot of drugs we are using nowadays, particularly the SGLT2 inhibitors, have the capacity to do this, working on these 3 channels, as you can see. Well, this slide just to remind you of the Credence trial. I'm not going to go through the details. You know the EMPA, REG, and the DAPA CKD trial. I'm sure by now we've heard so much about these trials and the significant results. And let me take you to endothelin receptor antagonists, another hormone that is serious to the kidney because it destroys the glyocalyx, which is protective and covering the endothelial lining of the capillaries, and this is serious as well as being a vasoconstrictive agent. Using atrasentan, which is the first of its kind, endothelin blocker, has been shown to reduce proteinuria, yet I have to caution you about a subcategory of patients that are liable to develop edema and those susceptible to heart failure. You should take care of these patients if you are going to use this drug and not to use it with them. There's another trial going on now looking at this drug away from both of these categories, those with high susceptibility to develop edema and heart failure, to really test the efficacy of blocking endothelin. Sparsentan was mentioned a month ago by Professor Hani Hafiz, and I really was very happy to hear about Sparsentan. This is the first of its kind. It's a dual endothelin antagonist plus a RAS blocker in one pill, and has been approved to treat the proteinuria and treat generally IgA nephropathy and focal segmental. Not generally talking about proteinuria, but since I'm talking about proteinuria, this is a specific disease area where sparsentan, as earlier mentioned by Professor Hani Hafiz, is approved. Well, this oral VX147, again, is a specific drug for a specific disease and a certain genetic allele mutation related to the apolipoprotein 1 genetic mutation. These type of patients, unfortunately, develop FSGS as well as dyslipidemia and develop serious proteinuria. And this particular compound or drug, not yet having a name, has been tested in these patients and showed quite good results in decreasing the amounts of urinary albumin excretion. This takes me to the last group, which is the GLP-1 agonist. You know the liraglutide and the once weekly semaglutide and dulaglutide. The good thing about these drugs, you can use them down to a GFR of 15. And what is new, what is really new, is the first of its kind, the twin incretin put in one injection, both a GIP and GLP-1, a glucose insulinotropic polypeptide together with the GLP-1 in one injection once weekly, showed marvelous results when compared to long-acting insulin glargine and degludec in relation to glycemic control. Recently, this man, Professor Herspink, reanalyzed the data of the SURPASS trials, which were 1, 2, 3, 4 testing the tirzepatide against insulin and also testing them against the old forms of GLP-1 agonists. And he arrived at the conclusion that there was a meaningful improvement in the GFR decline and a reduction of the urinary albumin creatinine ratio. We don't have this drug yet in Egypt. It's called Monjaro. I don't know how long it will take, but it's going to be expensive again. And this is my last slide. I'm not going to go through all the details of how these drugs work. I want to thank all our fellows who have joined our online fellowship in clinical transplantation, wishing for more and more of you to join us. And by that, I want to thank you all for your kind listening and waiting for your questions.